Okay, welcome back to the second half of the esophagus. Sorry I had to move areas. Hope you can still see. And so we just got finished talking about all the diverticulum. So let's go ahead and talk about some of the syndromes. So the main syndromes you need to know are going to be Mallory-Weiss. You want to know about the hiatal hernia, you want to know about GERD, and you want to know about Barrett's esophagus. Okay, so once you've got that core area figured out, then you just want to know about the two tumors that you see inside the esophagus. They're very common, or they're easy to remember, just adenocarcinoma, squamous cell carcinoma. Boom, that's it for the esophagus. Tumors can be confusing, because they can be everywhere and there can be tons of them, but as far as the esophagus is concerned, it's very simple, okay? You can either have an adenocarcinoma or you can have a squamous cell carcinoma. Okay, so Mallory-Weiss syndrome. Wow, this room sucks. Okay, so what you want to know about Mallory-Weiss is that Mallory-Weiss, there's just a few things, okay? It's very simple. What happens is, this happens in alcoholics, right? Okay. So with alcoholics, usually this is chronic alcoholics, all right, too. What happens is the alcoholics, they can have severe retching, which means it's going to present with some type of pneumonia or aspiration or something like that. They like to say that stuff, okay? They like to say a patient with some type of lung infection or reoccurrence of lung infections due to aspirations. So there's retching. Retching causes an increase in the linear or longitudinal tears. Okay? So we get these longitudinal tears that are usually at the esophagogastric junction in the proximal mucosa. Okay? So longitudinal tears, they like to say that due to retching, increased vomiting, and complications are that this can lead to like a severe GI bleed, and that's when it becomes a medical emergency. Okay, severe GI bleed. Okay, so that's pretty easy. There's nothing interesting or different about that. They can develop a mass, so this can lead to, you can see kind of a tear in the esophagus. And then there's hiatal hernia. Okay, so hiatal hernia is very easy. This is just idiopathic, all right? So usually it's just a congenital defect. We don't really know what causes it, but this is just a congenital defect, all right? So they're going to present with GERD. These patients, they present with GERD, all right? And a lot of our GERD patients actually, once we test them, we find out that they do have a hiatal hernia. Hiatal hernia, okay? So yeah, these patients, they'll present with GERD, and so what happens is normally when you have the bottom of the esophagus where the lower esophageal sphincter is, it's kind of squeezed by the diaphragm, right? And so then you have the stomach here, where we have the cardia, the fundus, the body, the antrum, and here's the pyloric region. So this is just normal, but when we have a hiatal hernia, this is what it looks like. So we have the top of the esophagus, and then we have the cardia and sometimes the fundus that kind of protrude, and then here's where the diaphragm is, and then here's the rest of the stomach. Okay, and so that's what it looks like. I hope you can see that, but it's just a sliding hernia. It's the most common sliding hernia, and it happens often, and it creates GERD. These people can also have bleeding and perforation, and if it has a perforation or a bleed, then obviously it's going to cause increased symptoms, okay? So the next thing we want to talk about is then GERD. Okay, so with gastroesophageal reflux, who gets gastroesophageal reflux? Anyone, right? Doesn't matter, but commonly presents alcohol or smoking. These are older, so greater than 40 maybe. Also, males more than females, and white people are the most common to get this. Okay, so we have males more than females, and then we have white people that are the most common to get this. So basically, anytime, this can be anything, but anytime you see this, it's the opposite of achalasia, basically, in principle. So what happens is with the lower esophageal sphincter, you get a decrease in tone. Okay, so it's relaxed. It's always a relaxed or decreased tone of the sphincter. And we can either have this acutely and it can heal, maybe some fibrosis or scarring, or we can have it chronically, right? And then chronically it relates to Barrett's, so it can cause Barrett's. So chronic can cause Barrett's. All right. These patients, how do they present? They have heartburn. They can have reflux. Can lead to aspirations. They can have dysphagia. They can even have a chronic cough. You know, the test questions they often like to ask, how does it present, and they relate it to a cough. So they have a chronic cough that usually manifests in the morning more than any other time. Okay, it can present as an upper GI bleed, so they can even have hematemesis and melena. All right, and that's pretty much it. So what you see microscopically with this, what you need to remember microscopically or histologically is that these people will have eosinophils. Okay, they'll have eosinophils and neutrophils, which is interesting. They'll also have a thick basal epithelium. Okay, and if they don't have metaplasia yet or whatever, they can develop that later. The only other thing that could be high yield as well is they get an elongation of the lamina propria. Okay, so elongation of lamina propria. All right, and that's what GERD is. Okay, GERD leads to whatever else you know about GERD. I'm sure just add it to this. Sometimes my mind goes blank. And then what it can lead to is Barrett's, right? So the cause of Barrett's esophagus is gastroesophageal reflux. That's the cause. That's it. Okay. So what you do is you get metaplasia in the esophagus. What's the normal histology of the esophagus? It's non-keratinized squamous epithelium, right? So non-keratinized. And then what we get is it becomes non-ciliated columnar epithelium. Now, what you have to do to diagnose this is you have to have goblet cells, okay? So just because we see columnar doesn't mean we can diagnose it. Remember, this also affects the Z-line, okay? So grossly, you can see the Z-line, and the Z-line is, you'll notice that it's white, right? And it's right here at the lower esophageal sphincter, and you can see it's white, it's squamous cell, and then underneath it is red for the ciliary epithelium, okay? Or for the columnar, I'm sorry. For the columnar, the non-ciliated. And so the problem with Barrett's, right, is that it causes dysplasia after time when we don't take care of it. It can cause dysplasia, and then that can lead to what type of cancer? Okay, this is at the lower esophagus. Anything at the lower esophagus, adenocarcinoma. Okay, not squamous cell carcinoma. Lower esophagus, adenocarcinoma. Mid and upper esophagus, squamous cell carcinoma. Same thing with the face. So the squamous cell carcinoma kind of extends. It goes all the way up to the bottom lip. Anything bottom lip and below, squamous cell. Top lip and above, basal cell, right? So that's pretty easy to remember if you can just kind of go with that. So adeno is lower, squamous goes all the way up to here, and basal's up at the top, okay, as far as your skin. So this is one of the two cancers that we see in the esophagus, and that's what we need to watch out for. So we always treat GERD, right? And we treat GERD to keep from becoming Barrett's esophagus, and then once we get Barrett's esophagus, the best thing we can do is monitor it, because they're not going to develop symptoms until a late stage. And when it's late stage, then it turns into our adenocarcinoma. Okay, so they can have dysphagia and things like that. They can have symptoms of it, but all these symptoms are not going to present until the later stages. Okay, so that's easy. The two esophagitis, esophagitis is in immunocompromised people. It can be fungal, it can be infectious, or even pills or allergies can cause it as well. So with the pills, it could be just long term. We often tell the patients when they're swallowing the pill to stand up and take a drink and then have it run all the way through, and that will decrease some of the esophagitis. When they have it due to CMV or a fungal infection, we want to give them fluconazole to bring their T cell count up. And once we bring their T cell count up, the Candida esophagitis will leave. All right. And then when it's due to allergies, we just deal with the allergy cave. You'll see eosinophils inside that. Adenocarcinoma. Shoot, I can't believe I already ran out of time. Adenocarcinoma, it's the main reason we get adenocarcinoma is due to Barrett's esophagus, okay? So we've already kind of talked about it. What you see is you'll be able to see the metaplasia, plus at the bottom of the slide, you'll see a bunch of cancer, okay? You'll see complete dysplasia, metaplasia, dysplasia, and then cancer, all right? And so that should be pretty easy to recognize. 25% 5-year survival rate. Then if they resect it, it helps, especially if it's if it hasn't developed that much. These people, remember, it presents late, but they're going to have weight loss. They're going to say cachexia, some type of weight loss inside there. Same thing with squamous cell. They're going to say weight loss. They have dysphagia, and it's oftentimes progressive dysphagia, but that's more squamous cell carcinoma, okay? They're going to have chest pain, and they can have a hemorrhage, which is going to cause them to bleed out. And usually what you want to do is, the people who are at increased risk are the same people that are at increased risk for GERD. So tobacco, obesity, and things like that. To decrease your risk, you want to deal with fresh fruits and veggies. And then the last thing that we're going to talk about is squamous cell carcinoma. We've already kind of discussed it, but with squamous cell carcinoma, remember that it's everything upper and mid esophagus, okay? It's not going to be lower esophagus. And then squamous cell carcinoma, you're going to see keratin pearls microscopically. They're going to have dysphagia as well. The main things are achalasia or Plummer-Vincent syndrome or something like that in the esophagus that's going to lead to it. And so you'll see the keratin. You can see it kind of invading if you look at a slide. Also, grossly, you'll see the carcinoma, and then on both sides you'll see squamous. Okay, so you know that this is going to be, you'll see squamous epithelium, all right? So the three main things that you want to worry about are hemorrhage, you want to worry about metaplasia, or metastasis, metastasis, and then the last thing that you should really be concerned about are just aspirations, okay? That's it.